Today we're focusing on a critical failure point in emergency medicine, the misdiagnosis of acute aortic dissection.
Exactly. We're looking at why this condition, despite being so urgent, remains a huge blind spot in acute care.
Let's start right there with the urgency. For an acute case, what kind of clock are we actually racing against?
The clock is terrifyingly fast. Studies cite mortality between 1 and 2%
Okay.
per hour after symptoms begin. So every single minute a patient is on the wrong track, their odds get worse.
1 to 2% per hour. That means any error at the start is potentially fatal. So how often are we making that error?
It's alarmingly common. When you pool the data from multiple studies, the overall initial misdiagnosis rate is 33.8%.
A third. So 1 in 3 patients with aortic dissection are initially sent down the wrong path.
That's right.
That tells me we're working off of old assumptions, not current data. So where, specifically, are we going wrong in that initial presentation?
Well, it falls apart because the presentation is just a master of disguise. The main symptom, chest pain, is there in 67.5% of patients.
Which is not very specific.
Not at all. And back pain shows up in about 24.8%. But, those symptoms are universal in an emergency department.
So if the main complaint is chest pain, there's this immense pressure to rule out acute coronary syndrome first, right? It's so much more common.
That is the absolute core of the problem. The data clearly shows the most frequent wrong turn is a diagnosis of acute coronary syndrome.
An anchoring bias.
A powerful one. The urgency and the symptom location just scream heart attack to most clinicians.
And I imagine the overlap doesn't end there. What other common diagnoses lead us away from the aorta?
Oh, absolutely. Patients get misdiagnosed with neurological events like a stroke or a pulmonary embolism, even GI disorders.
Okay.
The presentation can be so complex, it just creates this diagnostic confusion.
Let's get into what I find really interesting. The specific factors that make a misdiagnosis more likely. What kind of atypical presentations should be a red flag, but often aren't?
Atypical presentation is the #1 driver, so a lack of pain or presenting with really mild, vague symptoms. Those are both strongly linked to a misdiagnosis.
Wait, a lack of pain. We're taught to look for this severe tearing pain. How common is a pain-free dissection?
It fundamentally changes the calculus, doesn't it?
It does.
Some studies suggest pain-free aortic dissection could be as high as 17% of all cases.
Wow. So almost 1 in 5 patients won't have that classic symptom we're all trained to look for.
Exactly.
Besides the absence of pain, what other conditions can muddy the waters and pull focus away from a primary aortic event?
Patients who show up with signs of congestive cardiac failure, they're also much more likely to be misdiagnosed.
Why is that?
Because a clinician sees the heart failure as the main problem, a typical pump failure. They don't always consider it could be an atypical complication of the dissection itself, like severe aortic regurgitation.
Let's switch to patient history then. If symptoms can be so misleading, what in the history should immediately raise suspicion?
History is key. We have to prioritize asking about hypertension. Pre-existing hypertension is the single biggest risk factor. It's documented in 55.4% of patients.
So acute severe pain plus a history of blood pressure problems. What other factors add to that risk profile?
A smoking history is very common. That affects about 30.5% of these patients.
Okay.
And we also see coronary artery disease in 14.7%, which
just complicates the differential with ACS even more.
Precisely. It makes it even harder to look away from a primary heart attack workup.
So how do you break that fixation?
You have to integrate the history with other findings, or maybe more importantly, with the absence of expected findings. We also need to ask about things like Marfan syndrome, that's in 3.7% of patients, or any previous cardiovascular surgery.
Right. And in the acute setting, we lean so heavily on the chest X-ray. Does that ever fail us?
Absolutely. This is a critical point. Clinicians are trained to look for a widened mediastinum on the X-ray.
The classic sign.
But the absence of that sign is a strong predictor of a misdiagnosis. About 20% of aortic dissection patients will not have it.
1 in 5.
1 in 5 will have a normal-looking mediastinum.
That's a huge false negative rate for a textbook finding. It really proves that relying on history and a physical exam alone is just a setup for failure.
Correct. The absence of one key sign should never give you false reassurance if the history is concerning.
Okay, before we get to solutions, we need to touch on classification. Remind us of the key difference between Stanford Type A and Type B.
It's all about anatomy. The Stanford classification is based entirely on whether the ascending aorta is involved.
Simple as that.
Simple as that. If the ascending aorta is involved, it's a type A. If the dissection only involves the descending aorta, it's a type B. That distinction dictates everything that comes next.
And what are the differences in management and outcome?
They're night and day. A type A dissection has an in-hospital mortality of 32.5%. It requires immediate, urgent surgery.
And type B?
Type B, if it's uncomplicated, can often be managed medically. Its in-hospital mortality is much lower, around 10.6%. So making that distinction is the most important step after the diagnosis itself.
Okay, so given the high mortality and that 33.8% misdiagnosis rate, how can providers practically reduce these failures? What can we do?
The first and most accessible thing is simply getting a better history. Clinical suspicion has to lead to more structured, more comprehensive questions.
You mean asking about family history, pain characteristics?
All of it. Guidelines recommend establishing risk with very specific questions right at the start.
Let's zero in on the pain assessment. How do we get more useful information when it overlaps so much with a heart attack?
We have to get past just chest pain, yes or no. One study showed that asking just 2 or more detailed questions about the character, the onset, severity, radiation led to a much more accurate diagnosis.
So focusing on that sharp, abrupt onset.
Exactly. The quality of the information is key.
Which brings up a big question. How should we be using our diagnostic tools, especially when we know the classic signs can be absent?
We need early and low-threshold use of advanced imaging, period. If aortic dissection is even on the radar, imaging has to be the priority.
We hear about resource limitations a lot. Is there data on how access to imaging, like CT scans, actually impacts the diagnosis rate?
There is. Resource availability is directly tied to success. One study found that having things like a contrast-enhanced CT scanner or 24-hour specialist coverage resulted in a 17.3% increase in correct diagnoses.
So system-level investment directly saves lives here.
It does.
What about outside the big CT scanner? Are there faster, cheaper tools that can help at the bedside?
Yes, point-of-care ultrasound is a perfect example. It's a rapid solution. It can help you spot an intimal flap or a pericardial effusion and immediately guide your next move. It's a great risk stratification step.
Finally, should we be using formal risk scores instead of just relying on clinical gestalt, especially with an atypical case?
Absolutely. Formal tools are essential for objectivity. Things like the acute aortic dissection risk score are highly sensitive. They force you to account for risk factors that your intuition might otherwise brush aside.
This has been a really important look at a high-stakes problem. What's the final practical takeaway for that frontline clinician?
Maintain an extremely high index of suspicion. You have to remember that aortic dissection is a mimic. It will look like a heart attack, it will look like a stroke, it will look like heart failure.
And don't be falsely reassured.
Never. The absence of pain or the absence of a widened mediastinum should not rule it out. In fact, it should prompt you to use a risk score and move to imaging faster.